So welcome everybody. This is a webinar organized as part of the IMI AMR Accelerator. Myself, I'm Frederik Deroose. I will be chairing this session and moderating this. I'm part of COMBINE, and the company is called Connecting Pharma. We have a joint webinar between COMBINE and GNA Now. And we have two excellent speakers that I know already for quite some time now. Gone other sessions together. So we have Marie Attwood from North Bristol Trust and the Southmed Hospital as the first speaker, and then Alasdair MacGowan, also from the so Professor Antimicrobial Therapeutics, University of Bristol. So I'm very happy that you are joining us for sharing your expertise and knowledge on a specific topic, which has to do with standardization and specifically in vitro standardization in antimicrobial drug development. We've done some sessions before on standardization of in vivo models. It's of course all linked together, but I think a lot of people appreciate the efforts to try to standardize more and more models in the AMR field. So we have a nice agenda today. So we first will have Marie Attwood, who will be talking about, so is there a need to implement standardization into an in vitro evaluation system? And also looking at it from a European grant perspective. Then Alasdair will follow the next session, and we'll be talking about 8 different in vitro modeling systems. Very much looking forward to this. And then we'll have plenty of time, of course, for questions. Just as a logistical thing, if you're not talking, if you can just mute yourself. And also, if you have a question, use the chat. So there is a chat box. You can either put your name or just put your question, but I will make sure that you that we have time for some questions. Okay, so welcome everybody. We'll start with the first presentation from you, Marie. We'll need to make you presenter. Just a second.
Okay.
Yeah, I think you should be able to share your screen now. Yeah.
Okay. If you can let me know if you can see the presentation.
Yes, we can. The floor is yours.
Oh, thank you very much. Thank you very much for the introduction and the opportunity to speak today. So the collaboration project that we'll be talking to you about is the GNA Now project. And for those of you who don't know, the GNA Now acronym stands for Gram-Negative Antibiotics Now, which is in response to the escalating antimicrobial resistance problem. So as I'm sure you're all aware, the drug development platform takes quite a long time to get antimicrobials from discovery through to the market, typically 15 to 20 years. And what one of the aims of this project was to try and reduce that time significantly. So we have a consortium comprised of 11 experts. And the plan was to work concurrently rather than sequentially. And these experts comprised of independent bodies from industry, SMEs, universities, research organization, and public bodies and non-profit groups. And you can see a little map of where we're spread across all over Europe. So obviously we have our own very specific expertise, but we have a lot of overlapping techniques which we can perform. So some of these techniques are MICs, time kill curves, and in vitro modeling evaluations. So one of those questions was, well, the main question is there a need for standardization in all of these overlapping skills? So as I'm sure you're aware, minimum inhibitory concentrations have been heavily standardized. So UCAST and CLSI have recommendations for MIC determination, which are in complete agreement with the recommendations from the International Standards Organization. And they have provided guidance documents for the broth microdilution method for the physical setup, reading, and endpoint determination, and also set up a set of guidance for the evaluation of other antimicrobial susceptibility test devices against that broth microdilution method. So why was that needed in the first place? Well, there was a lot of variation between sites locally and internationally, and that could be attributed to a whole variety of factors, such as the media, the manufacturers of the media, and also the batch within the same manufacturing process, and also differences in MIC determination, which sort of largely related to staff skill set. So the recommendations have been put in really to ensure that we get robust, reproducible, and high quality data, and that has been really effective, and we're all used to performing MICs in this very standardized way. So the question really is, for the other type of evaluation tools, is there standards in place, or should there be standards in place? So the next step really in the drug development process from MICs, we'll be looking at time kill curves, and that's to determine growth patterns, either static patterns or sidle patterns. And I'm sure you're all familiar with these growth patterns, but if we have a look very quickly at the time kill assay graph, you can see typical growth patterns. So if you look at the growth control, which is in the black line, you can see the bacteria is, there's no antibiotic to inhibit the growth, so it just grows up normally up to 24 hours. If you then look at the blue line, which is compound 3, which I probably should have reorganized the order, you can see that this compound really has little effect on the bacteria, and therefore it also increases in growth. So this compound wouldn't probably be taken forward to the next stage of evaluations. If you look at the red line, which is compound 2, you see this very static flat line, which may be effective if you take into account host factors, maybe in vivo methodologies. And then you look at the green line, which is compound 1, we have that very typical biphasal growth curve with rapid rate of kill followed by a period of stasis. So at this point, there is no recognized standardization considerations, but there are sort of certain recommendations which are open to interpretation. So one of these interpretations are the size of the culture vessel used for time kill curves themselves. And we will talk about this a bit later as I go through this presentation, but as you can see, you can form time kill curves in large culture vessels or small microtiter trays. There are other influencing factors, which I won't go into detail today because Alasdair will talk about in his presentation, but we know from MIC studies that these factors on the slide that will have an effect on bacteria endpoints and bacterial bioburden. So what was our initial concept? We wanted to look at a ring study and where we would determine precise methodologies for each site. So being a scientist myself, I'm aware that we keep our methodologies and SOPs very close to our chest, and we're generally quite reluctant to share. But everybody in this study was very happy to provide those precise methodologies, and so we can understand the nuances between each site. And we also wanted to look at replications for time kill curves per site, per day, and also different day replications. And once we established whether there was consistency there or not, we also wanted to look at cross-site consistency or variations for same day and different day variations. The technical details of the time kill curve. One central lab, which was MBT, sent out the bugs, the drugs, the media, and set certain targets. The strains we used were 3 E. coli strains, a sensitive E. coli ATC strain, arguably equally sensitive ESBL strain, and a more challenging OXA48 strain. The drug we wanted to test was meropenem. The media to be used was in line with those ISO standards, so MHB2, which was provided by BD, and all had the same batch number. The targets we looked at was in multiples of MICs. So we had a growth control times 1, 2, 4, 8, and 16 multiples. Inoculum was 1.5 times 10 to the 6 at T0. A replicate, same day and different day, was equal to n equals 3. And the time points preferably were T0 pre and post antibiotic addition, T2, T4, T6, T8, T24. And where possible, sites were to measure the drug concentration throughout the experiment to look at degradation. So if we start off looking by the methodology comparison, I appreciate this slide is very busy, but really I'm just trying to get over the point that there was lots of variations between each sites at nearly every in every way. So if we break that down in a sort of more in a simpler way, there were some similarities, but not a lot. The main similarity was that the preparation of the inoculum was done by overnight culture for all sites, and the drug preparation, the solvent was aqueous, but that sort of was a given because we sent out the instructions with the drug as well. So the variations were numerous, and I split it into 3 main categories. So drug variation, the diluent used varied quite significantly. The dilution of the drug also varied, and the dilution series, if we were looking at 96 world trade time kill curves, varied from individual drug application to serial dilution. There was also bacterial variation, and the CFU of the starting inoculum varied from 10 to the 8 to 10 to the 10, but I think that was dependent on the equipment used. And as a result, the dilution of the inoculum also varied quite significantly. And depending on the size of the culture vessel, the volume of the inoculum added also varied. Then there's this last category, which is technical variation, which is basically for everything else I couldn't fit into the previous 2 categories. But the total volume of the culture vessel varied between 100 microliters to 30 mil. The CFU determining sample volume was between 20 and 100 microliters. And the culture conditions themselves also varied from static cultures to cultures which had been agitated with varying RPMs. So we have obtained a huge amount of data. So for all of the next slides, it's just really trying to give you a snapshot of what we discovered. But what I'm trying to get across to you here with this set of data is that you can see just by eye there are trends for all different sites, but there's a lot of appears to be a bit of variation across the board. And really the question is, how significant is this variation? And for that, we needed to seek outside help, because I'm not a statistician by any means. And we sought advice from an expert who advised us how to appropriately analyze this type of data. So for normally distributed data, which really is only associated with T0 CFU levels, we used a 2-way ANOVA. The assumption made is that it was normally distributed because there's no effect from the antibiotics. And the test statistics that we wanted to measure were repeated measures at T0 for same day and different day per site, and the same for same day and different day repeated measures between sites. Therefore, the null hypothesis is the expectation that repeated measures at T0 for both intra and inter-site are consistent, and therefore the alternative hypothesis is that they are statistically different. So as soon as we add antibiotics into the mix, then we can no longer assume normal distribution. So we have to use a different test. And the test used for that is the Friedman test, which was sort of new to me. We use that to assess rapid rate of kill at T4. So that's data points T0, T2, and T4. And also for regrowth for T24, which are data points from T6, T8, and T24. So they all have 6, which means that the chi-squared is going to be consistent for both things. So the Friedman test is a non-parametric test, which is often considered a non-parametric equivalent to ANOVA with repeated measures. And the really important thing you really need to take from this is that the threshold, which needs to be exceeded to ensure consistency, is 11.070. So in very, very simple terms, because I need it explained to me very simply, if you look at the graph on the bottom right-hand side, Anything above the line is good, anything below the line is bad. So if we have a look at some of these results for the inoculum using the ANOVA, what you can see here is there's some variation between sites. So if we look at site D, for same day replicates and also different day replicates, there's no significant difference, which means that the inoculum is consistent. But when we can compare that data with all other sites, there is significant difference. And then conversely, when we look at site E, for example, same day replications and different day replications, there are significant differences in the inoculum, and unsurprisingly, the same is true for cross-site comparisons. When we then go to look at same site inter-site comparisons, looking at rapid kill and regrowth, bear in mind that anything above the threshold, which is depicted with the dotted line, it signifies consistency. What we can say is per site, whether you're looking at rapid kill or regrowth, generally the sites are consistent with themselves, which is what we would expect. So the next question, is that true for when we compare across the sites? And unfortunately, bearing in mind that most of the scores are below the threshold is suggestive that there is significant statistical differences across sites for both rapid kill and also regrowth, and that is irrespective of the bacterial isolate being tested. So knowing that inoculum does have an effect when affecting bioburden, we took out the sites which had significant inoculum variation, and then plotted this out again. And what you can see is what you can see then is that the Friedman scores are still generally below the threshold, and there is sort of variations within the data points, which led us to sort of want us to do some more additional testing. So one single site, which was MPT, did some more tests, and there's a lot of data on this graph, so I'll take you through it as best as I can. So we wanted to look at the effect of the sampling size and also the culturing vessel, which is what you can see in the graph A, the top right-hand side. We looked at volume of culture from 10 mils down to 100 microliters, and also looked at the sampling size, which was 20 microliters to 100 microliters. So what you can see if you look at the 10 mil culture vessel is generally, irrespective of the sampling size, you get consistency if we're looking at a target of 1.5 times 10 to the 6. If you get, and that sort of generally increases as we go down in size. So anything really below 2 mils, you get significant variation. Then we wanted to look at the culture vessel size and also the impact of sort of bacterial concentration. So if you look on the graph, which is labeled B, what you have on the top left-hand corner is targets of 10 to the 8. Then on the other side, you've got 10 to the 7, and on the bottom, you've got 10 to the 6 and 10 to the 5. And what you can see is when you are looking at CFU per mils, which are approximately 10 to the 6 or below, the smaller the culture vessel, the more variation you get as well. And finally, wanted to look at the culture conditions, comparing static and agitated cultures. And what you can see on the right-hand side is the MIC multiples, which in a static culture generally die off and remain very low at the end of the simulation at T24. You get this sort of static effect, which is probably related to tolerance in biofilm formations. So after we've come up with this evidence, we wanted to then do a second experiment to see whether we could implement or ascertain whether the vessel size really plays a big part in this reproducibility or lack of reproducibility. So we tested one single bug. The drug was the same, media, target, inoculum, but we inserted acceptable tolerance ranges for the inoculum. So if the inoculum fell out of these ranges, they wouldn't be included in the data analysis. And we focused on the size of the vessel. So 10 mil glass universal time kill curves were to be performed and compared with 96 well plastic microtetra trays with a volume set at 200 microliters. These are the results for the 10 mil time kill curves. And what I hope you appreciate is that the data points for all sites are pretty tight, with the exception of MIC times 1 MIC multiple, which has a bit more variation at the 24-hour point. When we look at the 200 microliter data, you can see that the trends are, are again very similar, but the data points are spread out quite a lot, and therefore perhaps this would be statistically different. But just by eyeballing, we can tell that. So we did the same analysis as we did previously. And unsurprisingly, for both the larger culture vessels and the smaller ones, the inoculum showed no significance, which is good because we set those tolerance limits. But when we look at the 10 ml versus 200 microliters for rapid rate of kill per site and regrowth, you can see that 10 ml culture vessels exceed that threshold, and in comparison to the 200 microliters, where the rapid rate of kill fall below the threshold and still show significant differences. So then when we look at cross-site comparison for the 10 ml cultures, you can see that generally everything exceeds the threshold. So you've got more reproducibility, which is great, but with the exception of the ×1 MIC multiple. But when we look at the intersite replications with the smaller culture vessels, 200 microliters, you can see that rapid rate of kill falls below that threshold, which still means there's quite a lot of variation going on. And but if you look at the 24-hour data, you have overall more consistency. So where does that really lead us? Our conclusions are that the inoculum is important for antibiotic assessment, not just for MICs, but for time kill curves as well. And we believe that you should state tolerance levels for inoculum at the very beginning of the project. That the time kills, which are commonly performed in 96-well trays, have a larger margin of error. And if you're particularly looking at rapid rate of kill, it may be worth looking at performing time kill curves in larger culture vessels, really just because that the errors are likely to be associated with sampling size and the methodology for CF enumeration, which perhaps are not as sensitive. The literature does support the translatability between larger culture vessels and in vivo evaluations, and it's important to try and stick to the gold standard as much as possible. And that sort of then leads us to consider critical endpoints right from the beginning experiment. So what are we really interested in? Are we only interested in rapid rate of kill, or overall AUC, or maybe both? And similarly to the MICs, when they're doing mass MIC testing, which sometimes have a central lab, should we implement a central lab for time kill curves in a consortium? And really, finally, when we're looking at antibiotics, we have a very tried and tested method. But if we're starting to look at including novel therapeutics, for example, and evaluating in the same way, for example, like a endolysin or a tailocin or something like that, can you realistically get reproducible results, or is it just the nature of the entity being tested, which would mean that we wouldn't be unable to standardize anything? So there has been a reluctancy generally for when people try and bring in standardizations to certain elements. And really what we want to do is, rather than sort of dictate very, very strict rules, but which people sometimes rebel against, what we wanted to do is just highlight considerations to improve reproducibility. And that's really to ensure that we don't remove all scientific creativity. Yeah, I think with that, I'll stop sharing my screen and happy to take questions now or at the end of Alasdair's presentation.
Thank you very much, Marie, and certainly come back. Certainly don't want to reduce the scientific creativity, your final quotes, but I think we'll need to come back to the standardization discussion. maybe I don't see any immediate questions right now. What we will do is first go to the presentation of Alasdair, and then we can open the discussion again. So, okay, so that if that's okay. Alasdair, I will need to make you presenter. Just a second. Yes, you are now presenter.
Okay. Okay, hopefully you can see that.
Yes, perfect.
Okay, excellent. As Marie said, this is sort of part of a program in GNA Now, which was designed to look at, as well as time kill curves, in vitro models or in vitro dynamic models or in vitro pharmacokinetic models, whichever terms you like to use. We started with time kill curves because we thought that would be relatively straightforward. That proved not to be quite as straightforward as we thought, and so we haven't really got to the dynamic modeling part of this, and that's due to happen beginning of next year. But there are certain things we know about standardization in this area, and I think you can argue that standardization of in vitro dynamic or pharmacodynamic models is probably more important than kill curves, given the fact that we use these models to determine pharmacodynamic index drivers and magnitudes. I just show my conflicts of interest. We work with a whole variety of different academic and commercial groups, sometimes in mixed private-public partnerships, sometimes individually. But that's sort of what we're doing at the moment. And I suppose for the sake of transparency, I should point out that I'm a member of the UCAS steering committee, which is involved in breakpoint setting within the EMA. So I'm going to talk, at least at the start, about the factors which may impact reproducibility, and we know that from existing data. And I'm going to show data primarily from our own models just because I have access to that and I can tweak it around a bit. And if I want to be rude about it, I won't upset anybody. And then I'm going to talk about this paper, which was published by Axel Dahlhoff a couple of years ago, where he compared these 8 different in vitro dynamic models. Axel was an academic at the University of Kiel, but he also had worked with Bayer for many years, particularly on the development of ciprofloxacin, moxifloxacin, and a number of other compounds between these. And he had a lab running using in vitro models, and he was very interested in comparability across the different models that were used. And he organized a study and did some of the analysis of the data. And I will just go into it, but the reference is there. It's worth a look if you're interested in this particular area. I'm going to show you this slide from Jorgen Belita's review of pharmacodynamic systems, and it's just a list of things to think about when you're setting up a system, you know, what you need to think about. And I'm just going to pick on some of these different issues and show you the impact that they can have on outcomes when you run in vitro models. So the first one is inoculum, and Maria's talked about this a lot already, and it seems entirely self-evident, I think, at least to me, that inoculum is really important. And this just shows you some data that we developed using our sensitive Streptococcus pneumoniae with 2 different inoculums, 10 to the 6, 10 to the 8, a couple of different fluoroquinolones. And you don't need to be a genius to work out that with 10 to the 6, you get quite a lot of clearance from the model, and it all looks very lovely. If you go to 10 to the 8, the picture is completely different, in fact, where the organisms regrow and continue throughout the simulation. It also impacts on kill, and you're much more likely to see resistance emerging at high inoculum. This is the same data. The wild type strain is on the top there. You only really get a resistance emerging with at 10 to the 8, not at 10 to the 6. and you're more likely to get resistance with some resistance mechanisms at higher counts as well. So if you're interested particularly in pushing a compound or a modality, and you want to know about resistance, then obviously using high inoculum will bias the system to produce resistance. This is another situation. Sometimes you might be interested in a high inoculum. The reason why people are interested in high inoculum in both of these situations is really because the fluoroquinolones are obviously used to treat pneumococcal infection in the lung, and lung infection is generally thought of as high bacterial load. And this drug, tobopenem, was a Roche anti-MRSA beta-lactam. It's a carbapenem. It never reached clinical practice, but there was enthusiasm to see what the effect would be at high inoculum MRSA infection, like pneumonia, and low inoculum infection, say like skin and skin structure infection. And as you can see, with a 10 to the 6 inoculum at the top part of the PowerPoint here, you get clearance, and you get less clearance when you have a high inoculum. In both of these studies, there's also the issue about growth phase, which again Marie mentioned, and growth phase I'll come back to, but does have an impact on speed of kill. And I've just pulled this out of a paper by Eng, which is actually a time kill curve paper, but it just shows the CFU killed in the following phases. So it's slightly confusing, this, and I'm sorry about it. So positive numbers, large positive numbers mean more kill, and negative numbers, I think, mean growth here. But if you look across at some of the agents, miropenem, for example, at 5 milligrams per liter, which is the second line down on the table, then in non-growth phase, you get a certain amount of kill. With suboptimal growth, you get a bit more, and with optimal growth, you get more yet. So it may not just always be the inoculum, 10 to the 6 or 10 to the 8. It may also be how you prepare that inoculum and what growth phase the bacteria is in. It's obviously more likely to be in growth phase at 10 to the 6 than it is at 10 to the 8, at least in our model, because about 10 to the 8 is the maximum bacterial load per mil that the system will sustain. The other thing to think about is media, of course, and this can be very vexing. This is a molecule, again, we looked at as part of the consortium, the GNA Now consortium, NOSO 502 from Nosophon, and this is a peptide antibiotic, and we were interested in what the strength of Muller-Hinton broth might have in terms of bacterial kill in model systems, and we've got here 100% and 50% Muller-Hinton. 50% is the triangle, and the 100% is a circle. We also added some tween to this because we were a bit worried at the time about binding to plastic in the model, but that didn't seem to be too much of a problem. But you can see that if we use lower strength Muller-Hinton broth, then the killing is increased, and that this has a direct effect on the AUC-MIC, which is the primary driver for this molecule, both in vitro and in vivo systems. And you can see that if you use 50% broth, then your static effects are very much lower than they are with 100% broth, and they're more in alignment, not quite in alignment with animal data, which was done with our colleagues at Deroose in the Netherlands. And I think it's well known now that in Muller-Hinton broth, there are inhibitors of peptides, and this is presumably what is going on in this system. There are other things to worry about as well, and this is another of them. This is taniborbactam, which is a beta-lactamase inhibitor, and it's really looking at its activity in different concentrations again of Muller-Hinton broth. And this is addressing the issue of zinc concentrations, which are high in 100% Muller-Hinton broth, and you can reduce by using reduced concentration of broth. And as you can see, if you look at the concentration of drug required, say in 100% broth, to get a 4 log kill, it's about 7 milligrams per litre, while in the bottom graph, it's well under 1 milligram per litre. So that has a huge impact on potential conclusions you might have, depending on what the particular constituents of your broth are. And of course, the issue of iron comes into view as well for siderophores. So we know that that is going to be important. The time that you measure your endpoint at is important too. This is ceftaroline against Klebsiella pneumoniae, and I just show it to you because it shows that the time over MIC for static effect, for example, increases from 24 to 48 to 72 to 96 hours. And the next slide just shows the same with piperacillin and tazobactam against Pseudomonas. I'm not going to really dwell on it, but it shows that the static effect goes from about 40% at 24 hours to over 80% at 72 hours. And that's maybe not too surprising. Species is important, and I think generally with models we tend to focus on the species that are important to the potential indications of the drug or the therapy that is going to be used. And this illustrates what are pretty well-known differences between E. coli and Klebsiella pneumoniae in terms of beta-lactams, where the static effects are often the same, but the side effects are different. So if you look at the static effect for E. coli, it's about 35%, and Klebsiella is 36%. But if you look at the time over MIC to produce a 3 log drop, it's 40% for E. coli and 80-odd% for Klebsiella pneumoniae. What I really want to show you on this table, however, are the strain differences. And if you look at the Proteus mirabilis, you'll see that there are 4 strains of Proteus mirabilis tested. And the bottom 2 there have been tested twice because the results were so different from one another. So the strain at the top of the pile, which is 45322, the amount of drug needed for static and killing effect is very low in both replicates that we did, while for the strain below, which is 45266, they are very high. So even within species, you will get differences between strains. This is a particularly acute example, if you like, and that's why I picked it. But there are other examples where there are important strain-to-strain differences. And if you're comparing across models and you're using different strains and they are likely to produce very different outcomes, that will certainly serve to confuse you. This again is taken from GNA Now. At the moment, we're working with gepatitacin and we're looking at enteric pathogens. So these are Shigellas that we've done in dose ranging experiments. And I've just shown you the 5 strains, and they've got similar kill patterns and exposure patterns, apart from Shigella EN018, which is on your right-hand side in the middle panel. And as you can see there, the AUC-MIC for static effect is a little bit higher than the others, and unlike the other 4 strains, it doesn't appear to be killed. And that seemed very odd to us. We also noticed when we were looking at resistance studies that the population profile of this strain is slightly different. So I've plotted the population profiles at time 0 on here, and EN018 is the green one. And as you can see, it's the only strain where prior to exposure to the drug, you get growth on MIC2, 4, and 8 plates. And we know from previous work that that initial heterogeneity in this way, population heterogeneity, is associated with poor kill and emergence of resistance. And this is certainly the case with the Shigella strain. And this plot, which again is a little bit busy, but it shows you the AUC MIC versus the counts on MIC times 2 and 4 plates at 24 hours. The black symbols are the 4 strains, which are not EN018. And as you can see, you get this inverse U-shaped curve. And at high exposures, you kill the organism and you suppress emergence of resistance. However, with EN018, which is in red, right across the spectrum, you get colonies growing on media with ×2 or ×4 the MIC in it after 24 hours. So it just really illustrates strain to strain variation in a rather nice way. The endpoint can also be important. And again, I just pulled this data out of some of the work we've been doing on gepatitacin, just because I had it handy. And this is a different Shigella strain. And I've plotted the AUC-MIC ratios of 20, 30, and 40. And the reason I picked that was that you can see at 24 hours, the log change in viable count, or the viable counts, are all pretty much the same. However, if you look at the shapes of the curves, they are very different. So there is an increase in killing between, let's say, 0 and 12 hours as you increase the AUC-MIC ratio, and then you get grow back. And the question is, well, can you encompass that in some endpoint? And would it be better to have that encompassed in an endpoint than just the log drop? Because we get a lot more information from dynamic models. We tend to use the log drop at 24 hours because that is what is used in animals, and we want to correlate with animal data. But in fact, in an in vitro dynamic system, the data is a lot more rich than that. So what we've done here actually to try and encompass that is to measure the area under the bacterial kill curve, which, like the area under the serum time kill curve, is just the area under the curve. So you can see, for example, with the AUC-MIC experiment, the area under that is going to be less than it is for the AUC-MIC 20 curve. And you can run your analyses, your sigmoids, using these different endpoints. And I've just illustrated these here against the 5 Shigella strains that, E. coli strains, I beg your pardon, that we've looked at this with. And to cut a long story short, basically the IC50s that are required for when you use an AUBKC rather than a log drop are all smaller for each strain, and also for the pool data, which implies perhaps that the D24 might be is probably a more conservative endpoint than using the AUBKC. And that just shows the graphical data, which I shall just pass on for the sake of brevity. So we know that these factors are important: inocular, media, timing, species, strain to strain variation, and endpoints. And by consensus, I've just sort of listed what generally happens. It's not always like this. We generally use 10 to the 6 inoculum. We generally use Muller at various strengths. Sometimes you might want to use low strength because you're going to use a lot of broth in some of these big dilutional models, and you want to keep costs down. Generally, we use a log drop at 24 hours, but as I say, we lose a lot of information when we do that. Species generally select themselves, but it's really important, I think, that we have a panel of organisms that we can use within that species across different models, different in vitro models, different in vivo models, so that not everybody is using different strains. And again, I think because the information is much more rich coming from in vitro systems than in vivo systems, then there is an opportunity to use different endpoints, at least in sensitivity analysis anyway. Gives you an idea as to whether log drop is a conservative endpoint or perhaps an optimistic endpoint. And then finally, I'll just touch on this paper of Axel Dalhoff, which I discussed, and that's the reference there. If you're interested, it's open access. You can download it and have a look at it. It's quite a there's quite a lot of information in it, which I can't really do justice to. And there was quite a lot of background analysis done with this data, which is not actually in the paper. Axel elected to write a primarily descriptive paper, which I think is fine, in fact. But basically, the study design was that moxifloxacin was the antibiotic, and like the time kill data that Marie described, this was all provided for all of the centers. That we were asked to model a certain concentration and 2 different half-lives, which had slightly different area under curves. One had a long half-life of over 10 hours, the other had a short half-life of 1 hour. And then there were 3 bacteria provided, ATCC, a strain which was really sensitive to moxifloxacin, an E. coli M1, which had a mutation, which had an MIC of 0.5, and also an ATCS pneumoniae with low MICs. Brain heart infusion broth was used in these experiments and all the simulations, and that again was provided. And then there were 8 different models used across slightly fewer centers. I think there were 6 centers. I'm not really going to talk about the sedimentation model that we used in Munich, because it's not used anymore. It was basically a system where you put antibiotic into a tube, leave it for a certain length of time, you spin it down and then resuspend, so you get a stepwise kinetic profile. However, there are a number of models that were derived from the Grasso model. Grasso published his model in the early 1980s. There's a Grasso model which we still run today, and our Grasso model actually is derived from the Wiedemann-Grasso model. It was set up in the late 1980s and early 1990s based on the model that Wiedemann ran in Bonn. And he ran a couple of different models, and Dalhoff himself ran a Grasso type model. So these are all dilutional models. And then there are models where, and the concern with these models is washout from the central chamber. And this can be corrected for in a number of different ways, mathematically, as in model 4, or you can use membranes to protect the dilution. There's a Swedish model that was used in Uppsala, which did this. There is the hollow fiber model, which we ran in Bristol. And then you can use dialysis tubing type model. The principles are all the same, that you're trying to stop washout, and that was a Dalhoff model. So there's a number of different approaches here. And in the analysis, we looked at a number of endpoints, such as log count at time 0 and 24 hours. We looked at area under curves and looked at kill rates, for example, and time to kill 3 log of organism, which is not on here, but I'll come back to. Excuse me. And if you want to look at the data, it's on tables 1 and 2 of the paper. I've removed model 1 from the analysis I'm going to show you, because it's not a real dynamic model, and it's doesn't tend to be used. And I've included model 4 as a Grasso model, despite the correction, because if you look at the data, the correction makes very little difference to the overall conclusions from that model. And that just shows you the table. They've got the tables have got E. coli on them. It's the M1 strain. Let me just stop that. And the pneumococcus. The ATC strain, because it was so sensitive, was rapidly killed, and there were no real differences between the models. This is the analysis then of the short half-life data. And we picked the short half-life data because that is one where there is most likely to be washout. And it's really comparing the grassome models to the other models. And to cut a long story short, you wouldn't expect there to be a difference in the inoculums at time 0. You might expect the time 24 counts in the grassome models to be lower if there was significant washout. That is not the truth. Not the case. The area under the bacterial kill curves might be lower, again, in the grassome models if there is significant washout. That is not the case. And the kill rates are not different either. So this allowed us to conclude really that that washout in dilutional models is probably not an important technical factor. What did seem to be an important factor, however, was the growth phase when people set up the model both for the E. coli M1, get rid of that, and the pneumococcus, where if the inoculum was an early log phase, there was more rapid time to log 3 kill than if the bacteria were in late log or stationary phase, which sort of underlines some of the things that Marie was saying in terms of time kill curves. So to conclude then, we know that there are a number of technical factors which are going to impact on the outputs from these models, and they're listed here: inoculum, growth phase, media, species, strain. I didn't talk about mutational frequency, but it's certainly out there in terms of the literature. Population profiles, time of exposure, and probably what endpoint you pick. However, it's not really known what the relative importance of these things are, and what is the ones that really focus on. And I think that's really important. And hopefully, when we're able to do some further external quality assurance with these models, we'll be able to perhaps reduce the size of this list and point out to people what are the really important things to focus on. But I'm rather suspicious that it will end up being inoculum and growth phase mostly. There are also a lot of other factors which we could consider, such as sampling, confirmation of drug concentrations, etc., etc. So that there's more to this than I've just touched on today. But anyway, thank you for your attention, and obviously really happy to take any questions or any discussion.